Good evening, and thank you for joining us for this live Facebook and Zoom event. This presentation is brought to you by Kavana Consultants. I am Dr. Leah Baynard, an occupational therapist at Kavana Consultants in Tallahassee, Florida, and I am your host. Kavana Consultants is an outpatient occupational therapy service practice specializing in low vision services, fall prevention, home assessments, and modifications. In observance of National Diabetes Month and Diabetic Eye Disease Month, which is November, this event's purpose is to bring you awareness of diabetes management and how to prevent diabetic eye diseases, treatments available, and how to maintain independence with visual impairments. We have assembled a small group of experienced presenters who will share their expertise in their respective fields. Presenting first this evening is Dr. Otis Kirksey.
Good evening.
Dr. Kirksey received his Bachelor's of Science and Doctor of Pharmacy degrees from Florida A&M University. He is a retired professor of pharmacy with over 25 years of experience in academia and almost 35 years as a practicing pharmacist. Dr. Kirksey is board certified in advanced diabetes management, as well as a certified diabetes care and education specialist. He is a certified life coach, as well as a master trainer for the National Diabetes Prevention Program. Dr. Kirksey currently serves on the board of directors for the American Diabetes Association and its National Advocacy Committee. Next is Dr. Appiah. Dr. Appiah is an ophthalmologist with Capital Eye Consultants and a board-certified retina specialist in Tallahassee, Florida. He is a graduate of Harvard Medical School with over 30 years of experience. Dr. Appiah specialized in medical treatment of diabetes retinopathy, macular degeneration, retina detachment, just to name a few. It is noted that he is regarded as an authority in the field of ophthalmology and has contributed to several case studies and original research efforts while being featured in many of the industry's top periodicals. He has been the recipient of numerous awards. Last is Cheryl Haynes.
Good evening.
Cheryl is an occupational therapist and the owner of Kavana Consultants. She is a graduate of Florida A&M University in occupational therapy with over 30 years of experience. She is certified as an assistant technology professional from the Rehabilitation, Engineering, and Assistive Technology Society of North America. Her work experience has involved numerous practice areas within the profession. She has worked with various visual diagnoses while working for Maryland School of the Blind in Baltimore, Maryland. She is active in her profession and with professional organizations to include American Occupational Therapy Association and Florida Occupational Therapy Association. In current practice, Cheryl specializes in low vision, fall safety and prevention, home assessments, and modifications. The format for this evening will include presentations from each professional. At the conclusion, of the presentation, we will have question and answers in which questions may be presented by Facebook or Zoom chat. We will monitor the questions throughout the presentation and submit them to the appropriate professional. I would like to thank our audience and our presenters again for joining us this evening, and we will begin with Dr. Otis Kirksey.
Good evening. First of all, I'd like to thank the Kavana consultants for inviting me to participate in this noteworthy event. November is Diabetes Month, and during this time, we focus on educating the public about diabetes prevention, and the complications that can arise as a result of diabetes. This evening, I will be speaking to you, providing just an overview in terms of what diabetes is, summarize the treatment, as well as outline steps that you may take if you don't have diabetes, that you can actually prevent yourself from prevent diabetes from developing in you. So sit back, and we hope that you enjoy this this presentation. Next slide. So the number of people with diabetes increases every year. We now have over 34 million people living in the United States with diabetes. 1 in 5 of those people don't know that they have diabetes. If you have 10 people in one room, at least 1 out of the 10 would have diabetes. Next slide. Now, diabetes, pre-diabetes is even more of a problem. We have 88 million people living in the United States with pre-diabetes. And astonishing, 8 in 10 adults don't know that they have pre-diabetes. And this is really something that can be resolved very easily. There are online risk tests that you can take that will give you an idea of whether or not you are at risk for diabetes. Next slide. So what is diabetes? Well, diabetes is a disease that is characterized by high levels of blood glucose or sugar in the bloodstream. That is referred to as hyperglycemia. And this is caused by an absence of insulin. And that absence can be either relative or absolute. And you'll find later on, we talk about the different types. Type 1 diabetes is associated with actually the body does not make insulin at all. So it's referred to as absolute absence of insulin. And type 2, the body may make insulin, but the body does not respond to it correctly. And therefore, it's a relative lack of insulin. Next slide. So the two items that we will cover, you hear them a lot tonight, insulin and glucose. And insulin is a hormone that is produced in the pancreas and secreted from the pancreas. And its primary job is to help sugar from the foods that we eat enter into the cells of the body. And why is that so important? Because sugar or glucose is our primary source of fuel for the body. Just like a car can't run without gas, your body cannot run without glucose. Next slide. So let's talk a little bit about the different types. Type 1 diabetes typically affects children, and actually disproportionately affects white kids more than any other group. Is associated with weight loss often. It requires insulin for life. So patients with type 1 diabetes, their body is unable to produce insulin. Therefore, they must inject insulin for the rest of their lives, or if they receive an artificial pancreas, that could resolve it right away. It is associated with an environmental trigger that often initiates the cascade of an autoimmune response. So actually the body attacks itself, producing antibodies, and these antibodies destroy the insulin producing cells. Next slide, please. Type 2 diabetes, which generally affects people in the third or fourth decade of life, is more prevalent among people of color, African Americans, Latinx populations, as well as Native Americans. It does not, people with type 2 diabetes don't necessarily require insulin for life, even though a lot of them do use insulin. It's highly associated with obesity. Actually, obesity is probably the most profound predictor of the development of type 2 diabetes. And while it's a gene has not been identified, there's strong evidence that it's familial, meaning that it's not uncommon to have multiple people in the family that have type 2 diabetes. Next slide. So let's look a little bit closer in terms of what insulin does. And if you see here, you have a cell, and you have the insulin receptor, and you have the round object with the red object is the glucose. And what insulin does is it's like a key. It opens up this channel so the glucose can slip into the cell. If glucose does not get into the cell, then that cell really begins to starve. It has not been fed. Next slide. So this is the normal blood glucose. You'll see that you have the red blood cells. You have the glucose here, actually, I'm sorry. The goal is the glucose. Okay, and so over here on the right side, you'll see where there are multiple glucose molecules in the cell. This is hyperglycemia. Should look like this. So here you have a tank that is almost a quarter empty with glucose. And here, that's because all the glucose has been absorbed or has been absorbed into the cell. Here, it's obviously there's a problem with the glucose getting into the cell membrane, therefore it collects in the bloodstream. Next slide. So when blood glucose reaches a certain point, and type 2 diabetes, which we'll talk about the most because it is the most prevalent, it's a really slow and serious process. You don't realize that you're going to the bathroom a little bit more. You don't realize you're feeling thirsty and drinking a lot of water. It kind of slips up on you. People experience slow healing. They also experience tingling in their feet. And in type 1, they will experience unexpected weight gain because what happens is that since insulin is not there, the body does not have the ability to utilize the glucose from your food, so the body begins to break down fat to make fuel, and that makes you lose weight. Diabetes also impacts sexual function. This is through its impact on the autonomic nervous system. Next slide. So when you have that, the body is exposed to large levels or high levels of glucose over a period of time, it has a detrimental effect on the body. And there are several serious complications can occur. You have cardiovascular disease, heart attack and stroke, hearing impairment. You also can have dementia, Alzheimer's disease. There are problems with your kidneys, problems with your nerves. Diabetic foot disease is very common and is one of the leading of below the knee amputations and poor healing or skin diseases. Next slide, please. Now there's good news because the complications that we see with diabetes can be prevented or delayed. That can be delayed, and that is through optimum glucose control. Next slide. So the effective treatment plan for a patient with diabetes includes, whether they're type 1 or type 2, includes education, healthy eating, blood glucose monitoring, blood pressure control, because there is a close relationship. You know, people with diabetes often die from heart attack and stroke. So we have to monitor blood pressure. We have to monitor cholesterol. We have to increase our physical activity, because physical activity actually helps the glucose into the cells, actually without the help of insulin. So having a robust exercise behavior can actually help lower your, improve your disease state. And medications, we have advanced, we've made tremendous advances with medications. Years ago, we only had the insulin from animal products. There was a lot of allergies and side effects. The drugs that we used were long acting and had a lot of complications associated with them, or side effects. Now we have drugs that can be tailored for the patient. If the patient needs to lose weight, we have drugs now that can help you lose weight, control your blood sugar, protect your heart, and help lower your blood pressure. So we're really excited about the new drugs that have come on board to manage diabetes. Next slide. So in addition to what your doctor, the treatment plan your doctor, your healthcare provider will put together, there are also self-care behaviors that people with diabetes should engage in, and if they do, should result in very good outcomes. I mentioned earlier healthy eating, and there is no special diet. You're getting where you fit in, a diet that is more comfortable for you. We do recommend that you don't go for the fad diets. Okay, you need something that's going to be sustainable for life. Being active, we encourage patients to get in at least 150 minutes of moderate physical activity within their tolerance. We want to make sure that you don't, if you're not capable of doing 30 minutes, 150 minutes a week, then you need to do what you can tolerate. Monitoring, which is not only just your blood sugar, but monitoring other things like your A1C. Have to get your A1C done at least every 3 to 4 months if you're uncontrolled, and every 6 months once you become controlled. Taking your medications, which is very important. That means you have to take your medications when they're prescribed. Read the directions on the labels. Make sure you follow them carefully. Make sure that you call for refills before you run out of your medications, so that you don't have a gap in therapy. Problem solving. That means, as you engage, if your blood sugars are running high the next one morning, you need to think about, what did I eat last night that could be contributing to my high blood sugars this morning? That is problem solving. Or if you're having lows, you need to identify what are the factors that are contributing to my low blood sugars. Reducing risk. Don't walk in the house barefoot. Don't walk outside without shoes. Remember, people with diabetes have poor wound healing. So if you do things like that, you could, damage your foot. It don't heal. It can get infected. If you smoke, you need to stop smoking. Smoking accelerates the cardiovascular manifestation of the disease and increases your risk exponentially for cardiovascular disease and stroke. And healthy coping, which is so important. It's not unusual for diabetes to be associated with depression. I mean, there is a phenomenon as diabetes distress. And so you need to make sure, if you're having issues, and family life can add to diabetes coping issues. So make sure that you not only take care of your physical health, but also that you address your mental health. Next slide, please. So we're almost finished now, but before we go there are the ABCs of diabetes, and these are the key, as I mentioned earlier, in terms of monitoring. You should know your numbers. By knowing your numbers, you know how well you are doing in your self-care behaviors to manage your disease. So A is for A1C, and this test actually measures our blood sugar over a 3-month period. is an excellent indicator. And the research says when you lower below 7, you decrease the effects of the disease on heart, blood vessel, kidneys, feet, and eyes. Next slide. B is for blood pressure. We want to make sure that the blood pressure goal is 130/80. High blood pressure makes your heart work too hard. It can cause heart attack, stroke, and kidney disease. So it's very important that you watch your blood pressure. Next slide. And finally, C is for cholesterol. Your LDL, which is the bad cholesterol, we want to get it below 100 is the goal. And our good cholesterol, which actually helps protect us, HDL, for most people, we want it to be above 40. Next slide. So we talked about the 88 million people that have diabetes. They don't have to they have pre-diabetes. They do not have to develop diabetes. The National Diabetes Prevention Study demonstrated that when people lost 5 to 7% of their body weight, and through eating healthy and getting 30 minutes of physical activity 5 days a week, you can lower your risk more than 50%, and that is tremendous. So, think about those things. Think about if you're not diabetic, go ahead and do the risk test. If, your primary care provider would be the ideal person to assess you for that, and then execute these lifestyle behaviors to prevent you from developing type 2 diabetes. And I think that completes my presentation. Now I would like to introduce Dr. Appiah, who's going to talk about diabetic retinopathy. Dr. Appiah.
Yeah, hello. Thank you for inviting me to participate in this special event. First, I want to say that diabetic retinopathy is the leading cause of blindness in people under 65, even in the United States. But it doesn't have to be, because it's treatable. And next slide. Yeah, this is a slide of the eye. Even though it's a small organ, it's very complicated. And all the structures are very specialized and very important. But diabetes affects the lens in the form of a cataract. So diabetics get cataracts faster because of the fluctuations of the blood sugar levels. Glaucoma, which affects the optic nerve from high pressures in the eye, are also more common in diabetics. Finally, the retina, which is the inside lining of the eye, has the most devastating complication from diabetes called diabetic retinopathy. But again, it's treatable. So if you're diabetic, make sure your primary care doctor sends you for an eye exam every year, preferably with an ophthalmologist or a retina specialist like me. The reason why I say that is if you don't have the special equipment to really analyze the retina and the blood vessels, you may assume that there's no retinopathy when in fact, indeed there is. Next slide, please. I'm going to show you some slides of patients who are diabetic and start with the color fundus exam. This is what you would see if you're an eye doctor and you're looking into the eye or you're taking a photograph of it. In this patient, the color photo looks pretty normal. That's the right eye. Next photo, please. This is the left eye, and it looks pretty normal in color. But we'll go to the next slide of the right eye. Okay, this is a fluorescein angiogram. We inject a dye of fluorescein in a vein, and within 10 to 15 seconds, it appears in the eye. Then we photograph it with a filter, and it will show the dye running through the blood vessels. This is very good because if there are any damaged vessels, the dye will leak through them, so you can tell which vessels are leaking and the extent of the leakage. Even though this patient had 20/20 vision, you can see that there are several areas with fluffy white leaking. That's the dye leaking out of the vessels. And other areas have very, very broad leaking. Those are not just abnormal vessels. They are new vessels created by the eye in an attempt to fix the ones that are damaged from the diabetes. So this patient has proliferative diabetic retinopathy, which is the worst stage of the disease, but he doesn't know it because he sees 20/20 and he thinks everything is fine. But he was sent to me, and the fluorescein angiogram showed that he needed treatment right away, which I started on both eyes. Next slide, please. And the left eye also has proliferative, again, the very white, fluffy areas are abnormal vessels developed by the retina to compensate for the ones that are damaged, but they are not as healthy as the ones the patient was born with, so they bleed very easily. And a bad cough or sneeze can cause them to break, and they'll bleed into the vitreous, which is the central cavity of the eye. So you want to prevent that. You want to come in, get examined, and treatment if necessary. Next slide, please. This is another patient with diabetes. She, on the other hand, has a few hemorrhages, red spots. So it's a dead giveaway that she has retinopathy. Next slide, please. And this is the right eye of the same patient. And if you look well, you see some red blotches. Those are hemorrhages. Next slide. And this is the fluorescein angiogram. Again, we inject the dye in a vein in the arm, and we photograph it with a filter, and it shows the broken vessels and where the hemorrhages are. Next slide. That was the left eye, and this is the right eye, pretty much the same. Because she had a lot of broken vessels that were hemorrhaging, we started treatment again. Now we use drugs we inject in the eye. You know, a lot of people are horrified when they hear that we inject a drug with needles into the eye, but the treatment doesn't hurt because we numb the eye for a while, we sterilize it, and then we do the injection. But they work very well, and they can actually reverse the disease. If a patient is reliable and they will keep their appointments every 4 to 6 weeks, we can actually reverse the disease back to the state where before the diabetes started in the retina. Next slide, please. And this is a patient who's a diabetic. Again, I'm showing this because the color photos look pretty normal. Next slide, please. That was the left eye. This is the right eye. And you go to the fluorescein, please. Next slide. The fluorescein looks almost normal, but there are a few white specks distributed around, which are broken vessels called microaneurysms. Those are the cardinal signs of the beginning of retinopathy. But you cannot see that if you're just looking at the retina with a lens. You need to take you need to inject the fluorescein to get an idea of whether the disease is starting and what stage it's in, so that you can design your follow-up appointments based on how advanced the disease is. Next slide. Yes, so this is the other eye with a fluorescein, very little diabetic retinopathy, but it's important that we notice that so we can tell her to come back every 6 months instead of 4 months or every 6 weeks if they need treatment. So again, I want to stress that getting a visit to an ophthalmologist or a retina specialist is very important. Excuse me. A lot of ophthalmologists are not trained to diagnose the disease, so they'll tell you everything is fine. In fact, you may have the disease and may need treatment in short order. So make sure you get your eye appointments once a year. And if you do have the disease, make sure you keep up with the appointment schedule they give you. Thank you very much for inviting me. And now I want to introduce Cheryl Haynes, who will talk about the occupational therapies applicable to treating low vision diseases. Thank you.
Good evening. Thank you for having us. Thank you for coming. I'd like to talk with you about what occupational therapy can do if you happen to have low vision. Next slide. Who are we and what do we do? Occupational therapy is a profession that addresses the ability to participate in what we call meaningful activities. Meaningful activities meaning occupation. So the occupation of living. So if you're retired, it's the occupation of retirement. The occupation of caring for yourself. So that's where that word occupation comes from. In low vision, we find that we treat a lot of different areas, and some of the areas that we treat are we teach people to use the remaining vision that they have and to complete activities, all types of activities. We help modify activities so that they can be completed even with reduced vision. And we teach people in the use of adaptive equipment to compensate for the vision loss. And finally, definitely what's important, we create a safe home environment to prevent falls and injuries that can result from low vision. Next slide. What is low vision? Low vision is a visual impairment not correctable by standard glasses, contact lenses, medicine, surgery, and it interferes with the person's ability to perform everyday activities. When you have low vision, you have it. Okay, Dr. Appiah was very clear about the diabetic eye diseases, and there's three of them that kind of go together, can go together. He's talked a lot about diabetic retinopathy, glaucoma, and cataracts. The next slides, I have some slides so you kind of see what it looks like if you have these diseases through the lens of an eye, if you have the advanced diseases. So you'll see the clear picture, and then there's diabetic retinopathy with the splotches all over the eye. Next, we'll have glaucoma. And what you see here with glaucoma, you see the narrowing of what we call the visual fields. Glaucoma is one of the diseases that are associated with diabetes also. Next, we have cataracts. Who doesn't know anyone that has cataracts? Everybody knows someone who has had cataract surgery. But with the cataract, this is what you see, that cloudy, blurry look, the fading of colors. A lot of people that start to have cataracts start to have problems seeing at night, especially driving, the double vision, also problems with bright lights at night. And diabetes also can increase the risk of cataracts. So what we do as occupational therapists, we look at your experiences and realize that people with low vision experience physical, economic, and psychological changes that diminishes their quality of life. Of course, you realize that there are a lot of things you can't do that you've normally been able to do, and you're affected by that. So as an occupational therapy, we come in and look at certain areas, several areas of your life, just to name a few we have here, and we assess those areas and we come up with strategies, or we come up with what we can call assistive technology. We can have what's called low tech or high tech assistive technology to help you to be as independent as possible. So some of these areas we talk about what we call activities of daily living. A lot of people understand that to be self-care, a lot of time with grooming and all those kinds of things. Bathing, to be able to go in the shower, and just simple things like to be able to locate the shower head or the nozzle. Instrumental activities of daily living, such things as meal preparation, financial management. We recommend low vision aids for your medical management, medication management. We also address home management, the ability to function within your home safely, within the home and outside of the home. We look at your ability to, outside of the home, to be an independent shopper with low vision, and reading for leisure and daily living tasks, and community and leisure activities. You have to understand, having low vision doesn't mean that your life has to stop. There's so many adaptive ways and adaptive equipment out there that if you happen to get this disease and it does affect your vision, you can still continue to live. And that's what occupational therapists do. We come in, we take a look at what's going on, and we come up with strategies specifically for you. Next slide. How do I get a referral? Referrals to occupational therapy. Referrals can be generated from your eye care professionals or your primary care professional, another healthcare practitioner, a family member, or you as a patient can refer yourself also. Best practice requires a recent examination from your ophthalmologist to address ocular health prior to an occupational therapy evaluation, because your ophthalmologist has all the necessary equipment and testing mechanisms to make sure that the occupational therapy, as occupational therapists, we can make a clear judgment of what's going on with you. There are certain evaluations that we perform. However, we rely heavily on what the ophthalmologist says in their testing. Referrals are appropriate when the severity of the visual impairment affects engagement with daily life activities. Next slide, please. That's the end of my presentation. I'd like to thank you all for coming, and we're going to take the time now and ask the panelists some questions that have come in for us. I have a couple. Let's see.
I have one. It's for Dr. Appiah.
Okay, hold on a second. You want to go ahead and get it?
It's for Dr. Appiah. How often do you recommend being seen by an ophthalmologist if you have diabetes or something to your eyes?
Well, whether it's a juvenile or adult onset, you have to get an eye exam once a year. But juveniles don't really need to start until they've had the disease for 5 years. But with an adult onset, you have to get an eye exam the same year that is diagnosed, because you may have had the disease for a while and didn't know it. Okay, so that's what we recommend.
Okay, we have one more for Dr. Appiah. Can I make an appointment with your office, or do I have to get referred?
No, you can just call the office and make an appointment.
Thank you. The next question we have is for Dr. Kirksey.
Yes.
How do I find someone like you to help me with my diabetes?
Well, there are diabetes educators if you live in Leon County. First of all, I work at Neighborhood Medical Center, okay, and you can become a patient there. And also Tallahassee, TMA, Tallahassee, Memorial Hospital, they actually have a diabetes center as well. And so you could make an appointment there. I highly recommend it. A lot of patients never get formal diabetes education, and you'd be surprised how far a little education how much it can improve your total outcome.
Hello. I think the next question is for Dr. Kirksey. If I have questions about my diabetes medication, can I get my pharmacist to help me understand?
Sure, they are highly qualified to respond, to answer your questions, and you should. A lot of patients don't take advantage of the pharmacists, and you need to demand that they provide you with the counseling associated with each of the medications. Anytime you get a new medication, or you have questions about your medication, you should inquire, ask your pharmacist, and that's what they're for.
Okay, the next two questions, I have one's for you, Mom, aka Cheryl. I see that you can recommend and train someone to use items to assist me with my vision loss. Does my insurance pay for that?
Well, it all depends on your insurance. What I can say is with the elderly population, a lot of adaptive equipment or assistive technology is not paid through your insurance, Medicare. But what I've found is that there are a lot of agencies out here, and I know in Florida, that have a lot of equipment that you can get for free, or you can get on a loaner status. Also, there are a lot of manufacturers that will give insurance. It is our job to help you find those things, but we know of a lot of resources, or we know other resources to help you get them. Now, one thing I can say is with treatment, it's not always the equipment that you need. A lot of times there are a lot of just adaptive methods that we recommend, or if you need things, we have found that I found things on Amazon, I found items in Walmart. It's most of the time it's finding the item that works, and it might be a simple item that might have another purpose, but for you, it's a different purpose. And another thing that's very important to us is that if we recommend a piece of equipment that can be viewed as costly, we want to make sure that's something that you're going to use, because what we don't want is product abandonment. So we focus on making sure that's the product for you, that's the product that you're going to use, and it's going to help you throughout your life.
I think we have one more for you, and it is for low vision treatment, do you see me in a doctor's office?
No, that's not what we do. In good times, not in pandemic times, you would be seen in either two environments. We have an office on Tennessee Street. You could come in for your initial evaluation there, or the optimal environment is for us to come to your home, because as occupational therapists, we believe that the environment in which you operate is the best environment for us to do an assessment. But because these times are not optimal times and we're in a pandemic, at this point, what we're doing is telehealth. We offer telehealth services, which is paid for by your insurance through video telehealth, and under some circumstances, we can offer telephone telehealth too.
I think there's one more question.
We have, I think she has one more question. She's trying to find it on the computer. Is it? Okay, give us a second. They're typing it in. I'd like to thank you all for coming. Up on the screen, you'll see, while we're waiting on this next question, you'll see the contact information for all of us. Kavana Consultants, Dr. Appiah's office on Wednesday Street, and Dr. Kirksey. And Dr. Kirksey has an email for you. Feel free to contact them. Feel free to make an appointment to see Dr. Appiah. Feel free to contact us if you feel that our services were for you. You're welcome to contact us on contact us through our website, which is KavanaConsultants.com. We have a way for you to email us through our info email, and we'd love to hear from you.
So the last question is for Dr. Appiah. Dr. Appiah, you said that diabetes-related eye disease is reversible. How long does it take to see improvement?
Remember, the disease is not curable, but we can reverse it in the eye. So it takes about a year or two, depending on how advanced the disease is when you first come in. But even if you started bleeding into the vitreous, we can reverse it so long as you keep your appointments. It takes about 6 to 8 injections a year, the first year, and maybe 3 to 4 the second year to really dry it up. So it's a major time involvement, but you can't put a time on your vision. We can keep you seeing so long as you keep coming in. So if it's not that advanced, we can probably reverse most of it within 6 months. And that's why coming in early is very important. But more advanced cases will take a while, probably a couple of years.
Thank you very much, Dr. Appiah.
Okay.
Well, I'd like to thank the panelists this evening for joining and for presenting a wonderful presentation. I'd like to thank all of our participants for coming. We hope that we gave you the information to inform your lives and to move for better health. Thank you for coming.